I am Saad Kenderian. I'm a hematologist at the Mayo Clinic. My work focuses on CLL and chimeric antigen receptor T-cell therapy, or CAR T-cell therapy, and I run a research program also focused on CAR T-cell therapy. Chimeric antigen receptor T-cell therapy, or CAR T-cell therapy, is a form of immune therapy. It's a form where we're using the immune system to attack cancer. In this way, we are engineering the immune cells, or the T cells, to become CAR T cells. To do that, patients go through a process called leukapheresis, where the cells are collected, similar to blood donation, and then the cells are shipped to the lab, either here at Mayo or at one of the companies that they have approved the products. And then the cells are engineered over a period of anywhere between 7 and 10 days. And during this time, the cells are engineered to become CAR T cells. So the T cells now are CAR T cells. And during this process, the cells are trained to recognize and kill cancer cells. And then these cells are frozen and are shipped back to us. And before these cells are given to patients, patients receive low-dose chemotherapy to make room for these cells. The purpose of the chemotherapy is to get rid of the patient's own T cells and make room for the CAR T cells, for the CAR T cells to find their way and go and attack cancer cells. The concept of CAR T cell therapy has been around for a long time, and it was first FDA approved for lymphoma in 2017. In CLL, it was approved in 2024. And it was approved for patients that have disease that have relapsed after BTK inhibitors, such as ibrutinib or acalabrutinib, and BCL2 inhibitors, such as venetoclax, so a double-refractory disease. And in that group of patients with double-refractory CLL, CAR T-cell therapy led to an overall response in about 2/3 of patients, but importantly, in about 20% of patients, CAR T-cell caused a deep, long-lasting remission, suggesting that the therapy can potentially be a curative therapy for CLL. In fact, the very first patient treated with CLL was treated in 2010, and the patient is still in remission. And there are many patients who are in remission now 5, 6, 7, 10 years later, similar to that first patient. Again, highlighting the potential for a curative therapy with CAR T-cell therapy. As patients go through CAR T-cell therapy, patients will need to stay around the treating institution for anywhere between 2 to 4 weeks. And during this time, patients are monitored daily and monitored for some unique side effects that happen with CAR T-cell therapy. Some of these side effects includes the development of what we call Cytokine Release Syndrome, or cytokine storm. And this is basically a process that the CAR Ts are going around. They are multiplying inside the body by thousands of folds, and they are chasing and looking for the cancer cells and killing cancer cells. And as the CAR Ts kill cancer cells, then patients get sick. And then patients can have fever, they can be in the ICU. Most of the time, we're able to treat this with specific infusions that calm down the cytokine storm. And in the vast majority of the time, this is fully reversible. Another unique side effect is the development of neurotoxicity, or encephalopathy, or the scientific name for that, we call it ICANS, immune cell effector-associated neurotoxicity syndrome. And this neurotoxicity is unique. Patients can have a bit of confusion. They can transiently lose the ability to speak. They can occasionally go into a transient coma. And in the vast majority of the time, this is fully reversible within the first 2 to 3 weeks after CAR T-cell therapy. So these unique side effects of CAR T-cell therapy happen early on, and that's why patients will need to stay around the treating center for 2 to 4 weeks. And then in most of the time, they are fully reversible. Another unique side effect is development of low blood counts, or cytopenias. And this happens in a significant percentage of patients, and at times it can last for a few months following CAR T-cell therapy. And during this time, where patients stay on antibiotics kind of to prevent any infection and continue to be monitored with frequent blood counts. But despite all of these side effects, CAR T-cell therapy is an exciting development in CLL, is a new form of therapy. It is a potentially curative therapy. And importantly, recently we looked at what we call the real-world data. It's patients that are treated not in the clinical trial, but on the FDA-approved therapy. And the results seem to be similar to what we've seen in a clinical trial, or perhaps even better in patients with double-refractory, highlighting that the effects of CAR T-cell therapy is applicable to the real world beyond clinical trials.
I want to express our sincere thank you to our patients, to the members of our Mayo Clinic Lymphoma Disease-Oriented Group, to the Mayo Clinic, and to the Goldman Philanthropic Partnerships for this generous gift to produce this series. This gift has an incredible duality in that it goes directly toward enhancing patient care and provider education. We are at a time of phenomenal rapid change in the treatment plans, the biology, and approaches to clinical care in patients with lymphoproliferative disorders. This project will serve to inform. Again, our sincere thank you, and in the words of Dr. William Mayo, quote, "The needs of the patient come first."